One very challenging injury that we see in orthopedics are injury to the cartilage, and arguably the most common location for that is the knee. And there are a number of treatment options for how to manage a cartilage injury in the knee. The easiest is as we get some miles on the knee and we get more of an arthritis process, which is technically just loss of cartilage. That's when we try to initially treat it conservatively, but when nothing else is working, then the main treatment for that is a knee replacement. The more challenging decision making is when it's not so much of an arthritis process, but actually an injury to the cartilage. So the example I use is instead of a gravel road, which is more of an arthritis process, let's say you have a pothole in the road. So the rest of the road is paved with normal looking cartilage, but there's one area that is injured, and that can absolutely cause pain. It can cause swelling. It can cause some instability where the knee feels like it wants to give out. That is where the decision making becomes the most challenging, and how we manage that is going to be determined by a number of factors. One is age, one is how big the area of cartilage injury is, and also just the activity level of the individual and their goals for how active they want to get after the treatment. So one injury that we see in younger patients is that they will actually get an area where both the cartilage and the bone tries to break free of the rest of the knee, and we call that an osteochondral lesion. And if the area looks amenable to repairing it, we can try to put that piece back onto the rest of the knee, and with the help of biology try to get it to heal, and then the function of the knee goes back to normal. If the lesion does not look like it would heal if we reattach it, then you have to take it out, and that's where you're left with that pothole in the road. If the pothole only involves cartilage, then we have a number of options. We can nowadays take cartilage from a different part of your knee and send it to a lab, and we can grow cartilage and amplify that cartilage, and then it's sent back to us, and then we can actually surgically implant that into the pothole so that we're basically filling in that defect with your own cartilage, and then it can grow back and become normal, healthy appearing cartilage, which then helps with the pain, helps with the swelling, helps with that instability feeling. If it's a bigger lesion, we can even do that with a larger piece of cartilage that we've processed in the lab, and it's still amenable to using your own cartilage if the rest of the knee looks okay. If it's a small lesion that either involves just the cartilage or a little bit of the bone, we can also move cartilage from one part of the knee to another part of the knee. There are different parts of the knee that have more demand and weight-bearing forces applied to it, and there are parts that are more sheltered from feeling those stresses. So we can actually lift cartilage from one part of the knee that doesn't feel quite as much stress with weight-bearing and put it into the area where it is weight-bearing. And that is, again, using your own tissue to move from one part where it's less important to another part that is more important, and that also can restore the function of the knee and decrease pain and swelling. But if that area is too big, we can't move too much cartilage, or we're gonna just create a new cartilage injury where we took the cartilage from while fixing the old cartilage injury. And in that setting, we can use cadaver cartilage, and we can take cadaver cartilage that matches the shape of your knee and core out a piece, almost like a golf course coring out the hole on the putting green, and then we can insert that into the defect so that we have now filled in the pothole, although it will be with donor cartilage, but we have good success with decreasing pain and increasing function because we've taken away that pothole in the road and replaced it with cartilage. It's just that it's not your cartilage. This is a type of injury where you are going to want to discuss with your orthopedic surgeon the various options, and that can range from no treatment to conservative treatments such as anti-inflammatories or injections, to doing a surgery where we biopsy the cartilage and send it to the lab and then come back later and implant that, to moving cartilage from one part of the knee to the other, or relying on cadaver cartilage to fill in the defect. While cartilage is arguably the more stubborn structure in the knee to manage, luckily we do have a number of treatment options, and at least in my opinion, you start off as conservative as possible and then escalate up until we find the right treatment that gets you the most relief. And luckily, even though cartilage can be a very stubborn condition to manage, we usually can find something that can significantly improve function and decrease pain, with the final pathway being one day doing a knee replacement.